Hello and welcome back. In this episode, we are exploring one of the most critical aspects of any cardiac arrest, the reversible causes. These are known as the 4H and 4Ts, 8 factors that, if identified and treated promptly, can significantly improve a patient's chances of survival. Let's break down each cause by explaining the underlying mechanism, how to recognize it during cardiac arrest, and how to manage it according to advanced life support protocols. Let's start with the first reversible cause, hypoxia. Hypoxia is one of the most common and the critical reversible causes of cardiac arrest, particularly in asphyxial arrests such as drowning, airway obstruction, or respiratory failure. According to ALS guidelines, treating the cause of hypoxia must be the highest priority in these cases. Hypoxia occurs when there is insufficient oxygen delivery to the body tissues. In cardiac arrest, this often stems from airway obstruction, for example, from choking, anaphylaxis, or soft tissue collapse. Respiratory failure, seen in cases like asthma, COPD, or pneumonia. Neurological depression or CNS depression caused by opioid overdose or head injury. Low inspired oxygen secondary to faulty oxygen supply or at high altitude, and prolonged apnea seen in situations like seizures or drug toxicity. During hypoxia, blood oxygen saturation falls, myocardial oxygen supply is critically reduced, anaerobic metabolism leads to acidosis, arrhythmias may develop. Eventually, hypoxia leads to pulseless electrical activity or asystole, especially if not corrected early. In asphyxial cardiac arrest, the primary insult is respiratory, and ventilation with high oxygen becomes the key intervention, not defibrillation. How to identify hypoxia during cardiac arrest? Following features help with the diagnosis: presence of cyanosis, low or falling SpO2 before arrest if the patient is monitored, poor chest rise during ventilations, flat or absent capnography waveform, history of choking, asthma, drowning, overdose, seizures, or trauma. On respiratory assessment, presence of vis stridor or silent chest, which may suggest complete obstruction before the cardiac arrest. Management as per ALS guidelines. Treat the cause of asphyxia, hypoxemia as the highest priority because this is a potential reversible cause of the cardiac arrest. Effective ventilation with the highest feasible inspired oxygen is a priority in patients with asphyxial cardiac arrest. The immediate action: open the airway, use head tilt chin lift unless trauma is suspected. In that case, consider jaw thrust, remove visible obstruction or use suction. Insert airway adjunct, use an oropharyngeal Girdle's airway or nasopharyngeal airway, and progress to supraglottic airway device like iGel if trained. Provide high concentration of oxygen. Attach bag valve mask to oxygen at 15 liters per minute and confirm visible chest rise. Ventilate effectively, 30:2 compressions to ventilations, or continuous with 10 breaths per minute once advanced airway is in place. Watch for improvement in end-tidal CO2. Adjust mask seal reposition if needed, and consider intubation if trained and equipment available, and it is essential if vomiting or aspiration risk or prolonged arrest. Reassess airway after movement or equipment adjustment. Confirm and monitor EtCO2 waveform capnography continuously. If hypoxia is secondary to a treatable cause, for example asthma or anaphylaxis, initiate cause-specific management alongside ALS. In patients with hypoxia as the primary insult, early effective oxygenation and ventilation are more likely to result in ROSC than defibrillation or adrenaline alone. In any cardiac arrest where asphyxia or hypoxemia is the suspected cause, for example drowning, opioid overdose, or airway obstruction, your highest priority is oxygen delivery. Effective ventilation with high concentration oxygen saves life. Treat the hypoxia first, the heart may follow. Thanks for watching. In the next video, we will explore the other reversible cause of cardiac arrest, hypovolemia. Until then, take care and goodbye.